provided me privileges. Yasuaki, can you hear me?
Yes, very good.
All right, this was not so easy to join.
Yeah.
No kidding. All right, well, Kelly has been working hard in the background. We have a couple of minutes. So I've learned a lot about how this session works, in case you guys don't know. All of the cases are one giant long movie. So you and I make an introduction at the beginning, and then all of you guys go to sleep. And then we call you in your hotel rooms to wake you up with a nice breakfast to have a discussion at the end.
Yeah.
Okay? So Yasuaki,
Yes.
at the very end, that's when we can speak with the presenters and have some conversation about them, even though all of the cases have already been behind us.
Oh, okay. Okay. Yeah.
We cannot speak anytime during the presentation.
Yeah.
So together we make a very short introduction. The audience may write something in chat. So all of the presenters and we should be looking in chat to see if there are comments about the cases.
Mhm.
There may not be, but regardless, somehow together, excuse me a second. Dr. Haskal. Hello? Hello? Yes, who is this? Yes, and for these current 2 hours now, Dr. James Stone is covering me from 7:30 to 9:30. I asked my fellow, he is covering me for these 2 hours, Dr. James Stone. Okay, so I understand, but can you page Dr. Stone for right now? I'm on the line with China right now for 2 hours. That's why he's covering me. Until 9:30, he'll jump onto the call. Thank you so much. Call for a massive PE right now when my partner's covering. Come in. So I think we're going to have a lot of discussion time at the end. And what it means is that we have to prepare some comments for each other as the cases go by. So I'm going to ask all of you as panelists to think of maybe a sentence or two or a point that you want to make about your case, or maybe you can throw something at Dr. Arai or me so we can discuss a little bit with you, or a comment at somebody else's case. Otherwise, the audience will forget about them because all the cases were in a row, and maybe they'll just remember the last case that we see. All right, so we're going to have to run this. We don't know what the audience will or won't give us. All right, sound good with everybody?
Yep.
Thank you. I don't know why you guys are muted. I'm not sure why. I don't think, maybe you didn't pay your full registration or something. Oh man, who's this guy with the blue mask on his face? Is that Chiang Kai-shek? I recognize that even across the planet.
We are still required to mask up in
even at home. This is what's amazing. He takes his precautions this seriously. Right now he's at home.
No. There's someone in this room. I will be able to take down when they leave. Yeah.
So Kyung Hong, and for all the speakers since you joined, all of the presentations are going to play in one long movie without interruption.
Yeah.
So what's that? So I ask for all of your help in thinking about comments about your case or everyone else's cases. So at the end, because we're going to have more discussion time that we need, so that we may need to fill. So let's make some notes as the cases go by. There's some really cool stuff. And we'll go from there. I think we are 2 minutes to starting. Dr. Arai,
Yes.
you say something for 30 seconds, and then I'll say something for 30 seconds or reverse order, and then they play the movie, okay?
I don't need 30 seconds. Only say hello.
Okay, you say hello, and then I'll
Yeah.
say a little bit of hooray, rah-rah, and all of that, and then they start extreme Netflix,
Yeah.
okay? Maybe I'll use that line. All right. Testing it out. I was going to say that Dr. Tang hasn't aged one bit, but that's been the same picture that he's had. And now that you're back in life, I realize that, in fact, you have not aged one bit. You're getting younger somehow.
No, that's because I have not had my COVID vaccine.
Oh,
Just joking.
Well, I'm very proud to be in the country that has maybe more vaccine doses than anywhere on the planet and has more vaccine cases than anywhere on the planet. The crazy disaster we have. So I hope you guys are getting your vaccines soon. I know that there's been an absurd difference from east to west. Professor Liang, how are you? It's good to see you. I'm sorry that I didn't say an individual hello to all of you, but I was only seeing 5 faces on the top of Zoom. I now see that the rest of you are here. I apologize. Dr. Parr, Dr. Tanel, welcome.
Don't worry. Good morning, everyone.
Hopefully you heard what we said, that we're going to have a group discussion somehow, like a big rugby scrum. Everybody's going to pile into the middle at the end.
Yeah, perfect.
Okay. You guys have bought some amazing cases, so I'm pretty excited.
To see the attendee numbers are slowly going up.
What is it that you're looking at?
I was just saying that it's good to see that the attendee numbers are slowly going up. We have 65 now.
Oh, I don't see that. Okay. I'm just answering Kelly. All right, she's telling me that we're going to start soon. Oh, I see, 76 right now. All right. Well, welcome everybody. We've just got the signal that we are live. My name is Zeev Haskal, broadcasting to you at 7:30 at night in Charlottesville, Virginia. A day ago we had snow, and now we have 60 degrees Fahrenheit. I'm very excited to be with you virtually. I wish we were in person. I know we all wish this. But this is really exciting to have this session at the opening of the APSCVIR, the Art of Breaking Boundaries. So I'm here with my co-moderator and very good friend and mountain climber extraordinaire and now musician, Professor Yasuaki Arai, and an absolutely phenomenal set of extreme cases. And you can see some of the panelists over here, and I've had a little bit of look at the cases beforehand, so I've had a little taste. And I think you're gonna like the taste of this meal. This is how this is gonna go. We're gonna play, for simplicity, all of the cases continuously without interruption. We're gonna invite all of the audience, and I can see the numbers are going up and up and up, to write your comments into the chat. And at the very end, we're gonna have a discussion amongst all of us and also try to bring in your comments. So you can write throughout the cases so you don't forget. This is a great event, and we're really honored to be here at the very beginning. Dr. Arai, comments from my co-moderator and friend.
Yes, hi, the old friend, my friend. So very nice cases. So let's enjoy, please.
All right, let the games begin.
Hi, I will talk about my recent extreme IR. Disclosure. The patient was 50s male, pancreatic cancer, and he was suffering from the ills caused by two strictures of the jejunum. Already he received long tube placement for the drainage. And when we inject the contrast, you can see here, this is the proximal side stricture. Our endoscopist tried to put a stent for this stricture and insert guide wire very deeply and insert stent delivery system. Maybe here is the stricture. However, with endoscopic approach, no stent could be delivered because of two tough kinks of the jejunum. So the problem is how to place a stent in the jejunum stricture. This is a proximal side stricture, and this patient has another distal side stricture. Of course, at first, to make the route shorter, I performed the percutaneous gastrostomy like this, and from here, put the angiographic catheter like this, and insert guide wire very deeply, and insert stent delivery system. Maybe here is a stricture, and fortunately, I could place a stent in the proximal side stricture like this. However, to reach the distal side, anal side stricture, the route is too long and too tortuous from the gastrostomy. This is a stent, proximal side stent, and inject contrast shows a dilatation of the anal side jejunum. It means distal side also there was a stricture. So making the repugnant access to the small intestine, think about that. Gastrostomy, it usually is very safe because the stomach wall is thick and very strong. However, small intestine, especially the dilated small intestine, percutaneous jejunostomy is dangerous because the jejunal wall is very thin and weak. So for the gastrostomy, usually we use a so-called anchor like this to fix the stomach wall to the abdominal wall. But for the small intestine, it's not so strong, very thin, it very easily. The hole became bigger and the intestine will fall down into the abdominal cavity. Of course, it must lead peritonitis. So the problem is how to fix the small intestine to the abdominal wall. But when there is a stent inside of the small intestine, we can puncture this stent and we can put the anchor like this, like this. This is much better situation for the small intestine. And very strongly we can catch the small intestine like this. And of course, we can puncture with a bigger needle and we can insert the tubes. And at first, I checked the position of the stent Fortunately, it is just under the abdominal wall, like this. So at first, insert the anchor like this. I used 4 anchors. And under this situation, I puncture the needle into the stent. And in this case, that time, and the anal side of the stent is not so fully covered by the strictures. So insert guide wire and the catheters, and then at first place another stent like this. So this is a 2 stent for the proximal side stricture. And the route is very, very long. So this is the anal side stricture. But from here, it was possible to put the stent delivery system from the jejunostomy to reach to the next anal side distal stricture and put the stent like this. So this is proximal side stent and anal side stent, and you can see the contrast flow very smoothly like this. So no major complication occurs. And symptoms of illness, of course, disappeared immediately. And intestinal tube was closed, clamped, but we kept that as a safety tube. And 1 month later, I have a chance to inject contrast from this safety tube. Please look at no dilated small intestine and very, very good flow. It's reached to the ileum and the colon like this. So technique of using bare stents as anchors may make a new field of small intestinal intervention. We can make jejunostomy bacterium-free, safely. Thank you very much.
I present a case of endovascular reconstruction of the gastrointestinal tract. This was an interesting case that was performed during my time in London, in the United Kingdom. I don't have any disclosures with regards to this presentation. I present a case of a 25-year-old female who sought to lose weight and was unable to do this through normal dietary measures. She ended up having a laparoscopic gastric bypass for weight loss. And as we can see here on the picture on the right, this demonstrates the surgical anatomy. An incision was made through the proximal portion of the stomach and also through the jejunum. From here, a loop of small bowel was swung up to the proximal stomach and a gastric pouch was formed, and that's called the roux loop. And the anatomical portion of the jejunum was then anastomosed on a side fashion to the small bowel, therefore allowing drainage of the biliary contents and stomach gastric secretions through into the small bowel. So this was a very largely successful operation. The patient dropped their body mass index from 52 to 26. They were very happy, and the patient achieved a pregnancy in the following year and then was discharged from follow-up. 4 years later, however, she ran into some problems. She presented with an acute abdomen and septic shock. From here, a CAT scan was performed, and it was found that she had massive small bowel ischemia with areas of infarction. She underwent a massive enterectomy via a laparotomy. And from here, we can see that everything in black was therefore resected. So the vast majority of the small bowel was resected. This left a blind ending gastric pouch. The jejunum was also excised, leaving a jejunostomy to allow drainage of the biliary secretions and gastric secretions. And finally, there was a terminal ileum stump placed within the distal ileum. From here, she wasn't over her problems quite yet. During her stormy post-operative course, she developed some upper GI bleeding, for which she had multiple angiograms and she ended up having a prophylactic GDA embolization. She also had 2 laparotomies due to clinical deterioration. Here they found in the final laparotomy that she had some stress gastritis, and she underwent a partial gastrectomy. We can see here on the picture on the right, everything illustrated in red from the stomach was then excised. And a gastrostomy tube was placed within the pylorus of the stomach, close to the first part of the duodenum. Here she improved. She had a very long postoperative course, however. This was complicated by multiple episodes of systemic and Lyme sepsis, and she had multiple collections drained throughout her course. Now, one of the problems that she encountered was that she had a blind-ending gastric pouch, and that meant that all the saliva that she swallowed was then accumulating within this pouch and had to be drained somehow because this was no longer in continuity with the gastrointestinal tract. So a nasogastric tube was placed throughout her stay, but eventually when she was extubated, she was unable to tolerate this, and she pulled it out multiple times and ended up having episodes of persistent vomiting of saliva and also had some saliva aspiration pneumonia. And so this obviously wasn't a good long-term solution. So we were then approached to see what options she had. Was there a way that we could then create an anastomosis between the gastric pouch and the pyloric stump to therefore create continuity of the gastrointestinal tract? Well, the surgeons weren't very keen in a hostile abdomen that had multiple drains and infections, a very fibrotic and scarred abdomen. So was there any endoscopic or radiological fix for this? Could we place a gastrostomy within the proximal gastric pouch? Yes, that was possible, but it was deemed a little bit high within the abdomen and close to the diaphragm to be able to achieve this. So we came up with another idea. So here we can see a picture of her anatomy. We can see here contrast has been introduced through the gastrostomy, which I remind you now lies within the pylorus of the stomach. We can see here contrast passing through the duodenal loops into the jejunum. And the idea was that we somehow had to bridge the space between the gastric pouch and the pylorus of the stomach, which was all fibrotic tissue. So from here, what we did is that we had the endoscopist place an endoscope from above to look into the gastric pouch. We removed the gastrostomy tube and placed a TIPS needle and TIPS sheath through this region. And to make sure that we were going to fire the TIPS needle in the right direction towards the stomach, what we did is that when we gently probed the soft tissues, and when the endoscopist saw the bulging on the inferior portion of the gastric pouch, we knew we're in the right spot, and then we fired the needle. Through this, we were able to place a wire into the gastric pouch. We can see here from this image from the angiography. And then through the TIPS sheath, we were able to place a 12 by 40 millimeter balloon. And this was really just to expand the fibrotic inflamed tract of tissue within the abdomen to allow passage of a internal external biliary drain. So from here, what we decided to do was place an internal external biliary drain into the gastric pouch that would allow the drainage of saliva. We also placed a pigtail drain within the distal stomach from where the gastrostomy used to be, and we can see here on the anatomy on the diagram. So this was good as a temporizing matter. And so what we decided to do was to wait. And a few days later, we then went on to the second portion of the procedure. Here we can see the anatomy of the biliary drain, the internal external drain, and the pigtail drain within the distal stomach near the duodenal loop. From here, what we did is that we placed a wire through the biliary drainage tube. We then removed the biliary drainage tube and introduced a 10 French long sheath and made sure that we had ample space within the gastric pouch. The pigtail drain that was in the distal stomach was removed. And through this, we placed a diagnostic catheter that passed through the second to third parts of the duodenum into the fourth part of the duodenum near the jejunum. And this was just to make sure that if anything untoward happened, we did have still access. So from here, what we then did is that we decided to employ a stent. So remember, we are now bridging this space within the abdomen between the gastric pouch and the pylorus of the stomach. So you can see here, this stent was placed over the 10 French sheath. This was a NITI-S stent that was covered at 16 French 18 by 80 millimeter stent. And so what this stent was able to achieve would be a closed system connecting the gastric pouch to the pylorus of the stomach. And we can see that quite nicely in this diagram here. We've injected contrast through the sheath, and we can see here contrast accumulating within the gastric pouch, then going through the patent NITI-S stent into the pylorus, and therefore connecting the GI tract, allowing saliva to therefore drain through to the small bowel. So fortunately, she got much better and was eventually able to be discharged. About a year later, she came for an endoscopy. We can see here an endoscopy looking through the stent. We can see here the endothelialized cavity and a patent stent. From here, it was decided that the stent was removed. This left a fibrotic tract connecting the gastric pouch and the duodenum. She ended up having a jejunal to ascending colon anastomosis to fully complete her GI tract. And on discharge, she was stoma-free, however, dependent on TPN, but alive and independent with her daily activities. So this therefore achieved independence from some very severe complications from a gastric bypass. Thank you very much.
Hi, thank you for this kind invitation. My name is Wei, I'm from Singapore. So I also share a case of old school rendezvous meets new school IVUS in DVA creation. So the steps in deep venous arterialization or DVA, we first have to cross from the posterior tibial artery to the posterior tibial vein and create an arteriovenous anastomosis. We like the posterior tibial vein because it directly supplies the deep plantar venous system, and in so doing have the ability to supply arterialized blood to the foot. The second step would be then to disrupt the venous valves below the ankle and seal off the stealing perforators to allow reverse flow in the plantar veins. So these are the two main steps in DVA creation. This is the brief history of how we started doing DVA by creating the fistula. You can see that the first method was using a re-entry device aimed at the wire placed from the posterior tibial vein at the level of the ankle, and we target the wire using an outback catheter. Right in the middle, you can see the other thing that we use. Instead of using a wire as a target, we use the balloon as a target, and this allows us to create the fistula in a much faster way. And subsequently, when we got very used to IVUS, we started using the IVUS guided crossing, in which we use a pioneer catheter, in which it has a re-entry needle that could be used for targeting to cross in the vein like this. So this has become the most common way of creating a fistula. So straight to the case, a 78-year-old woman with end-stage renal failure, diabetes mellitus, as well as ischemic heart disease. First told ulcer and osteomyelitis, has 2 previous angioplasties with rapid reocclusion. What the plan for her was to have a bi-supply foot revascularization. That's to say we're going to create a DVA, but at the same time we try to open up one of the tibial arteries to keep the foot alive while the DVA matures. So this is what a Doppler looks like beforehand. And this is what it looks like when we use the IVUS crossing. You can see the wire going from the arterial side to the venous side, and it is rather characteristic when you see the wire bouncing off a valve and moving up north. And this is what it looks like on IVUS as well. You can see the artery and then the vein, and this is relatively easy. And of course, you fire the needle through and you can see a wire going across on IVUS as well. So on crossing, what we do is that we inflate the AVF with a small balloon, and then we check with contrast injection to see that we're in the vein. And the next step was really to try to find the posterior tibial vein, as this was IVUS crossing. There's no marker for a posterior tibial vein, but in this case it was difficult. Went to all kind of perforators, all kind of unnamed veins. Again, you can see all the way down to the peroneal vein. Again, unknown vein, as you can see, so it's getting a bit frustrating. The question is, what do you do then, right? Because in this case, what we did was that we punctured again the posterior tibial vein this way. Use a standard rendezvous technique with a retrograde catheter, trying to feed the antegrade wire into the retrograde catheter this way. You can see that way. And this is what we do. And after some hunting, we connected the two from the DVA into the posterior tibial vein. And subsequently, we could cross over across to the whole venous arch this way, followed by standard DVA techniques in which we inflate the large balloon. These are 4 millimeters balloon across the arch, 5 millimeters balloon to do some valvulotomy at the level of the ankle, as well as a 4 millimeters angioplasty to really further dilate the AVF. Extensive valvulotomy followed by stent graft placement of the entire fistula. This is further balloon molding of the AVF. As we want to get supply both on the arterial side as well as DVA, we have to revascularize the ATA because it's totally occluded. Straightforward revascularization technique down to the dorsalis pedis, and simple balloon angioplasty of the occluded segment to get the arterial supply to the foot. Now we return back to looking at the DVA, what we call pinch-off analysis, in which we look at the area that we created the AVF. Very much often you see this area of pinch-off. This is just above the level of the stent graft, and this is easily treated with additional balloon mounted stenting, bare metal stent. This is what it looks like after completion. You can see bisupply to the foot, DVA flow, ATA flow. Level of the cuff, again, you can see flow through the native ATA as well as the DVA. And this is what it looks like at the level of the foot, below the ankle. Again, DVA flow, a flow for ATA, giving a bisupply flow to the foot. This is what the Doppler looks like prior to intervention, and this is what it looks like immediately after intervention with patent ATA as well as a DVA. And the patient remains so for the next 3 months with successful wound healing after transmetatarsal amputation.
My name is Jong Hyuk Yoon from Goshin University Hospital, Busan, Korea. It is a great honor to present my case at APSCVIR. My case is endovascular treatment of giant fusiform hepatic artery aneurysm presented with jaundice and hemophilia. Hepatic artery aneurysms are rare, but a clinically important phenomenon. Repair is recommended in those aneurysms greater than 2 cm in diameter. Management options range from reconstruction using prosthetic grafts to excision or embolization. Let me show you my case. a 72-year-old male was admitted with right upper quadrant pain and jaundice. To evaluate obstructive jaundice, a contrast-enhanced CT was performed. And about 11 centimeter sized common hepatic artery aneurysm was identified. Coronal CT scan also showed a giant hepatic artery aneurysm. The aneurysm extends to right posterior hepatic artery with fusiform dilatation. PTBD was performed for management of jaundice. Angiogram shows intrahepatic ductal dilatation due to extrinsic compression by aneurysm. We suggested patient to treat an aneurysm, but he wanted to be followed up and discharged. However, 3 months later, he was admitted due to hematomesis. Endoscopy revealed massive hemophilia from AOB. We planned a transcatheter embolization for prevention of rupture. SMA angiogram shows right anterior hepatic artery via pancreatic duodenal arcade. Celiac angiogram shows common hepatic artery aneurysm and fusiform dilatation of right posterior hepatic artery. Left hepatic artery, right anterior hepatic artery, and gastroduodenal artery were branching from the aneurysm. We plan to perform embolization of proximal portion of the left hepatic artery, right hepatic artery, and terminal portion of the posterior hepatic artery, and then common hepatic artery, in order to totally occlude the aneurysm. Left hepatic artery was selected and embolized successfully with microcoils. Distal side of the aneurysm was also embolized with microcoils. However, we failed to select right anterior hepatic artery, so we plan to embolize through the pancreatic duodenal arcade from the SMA. We use an implant vascular plug to embolize the proximal portion of common hepatic artery. SMA angiogram shows aneurysm sac was filled by gastroduodenal artery through pancreatic duodenal arcade. Embolization of most proximal portion of the right anterior hepatic artery was performed using microcoils. Final angiogram shows complete embolization of the aneurysm with the patent right anterior hepatic artery through pancreatic duodenal arcade. Follow-up contrast-enhanced CT scans obtained 3 days and 1 year after the procedure reveal complete occlusion and reduction of the aneurysm. Currently, the majority of these aneurysms are found in asymptomatic patients. prompt repair has been recommended because the risk of rupture. Endovascular therapy may be effective ways to treat hepatic artery aneurysm and to avoid the morbidity associated with open repair. Endovascular techniques include isolation, packing, and stent placement technique. We successfully treated giant fusiform common hepatic artery aneurysm by endovascular embolization. Endovascular treatment with variable embolization techniques can be effective treatment option for common hepatic artery aneurysm. Thank you for your attention.
Good morning, and thank you for the kind invitation. Today's talk is on endovascular management of PE. These are my disclosures. Now, if you look back to this 31-year-old female patient whom we treated quite a few years back, orthopedic surgery, recent surgery, came into A&E with massive PE. Blood pressure was 60 systolic. So we took her in, and as you can see, the angiography confirms the presence of a significant PE. You can see a snare catheter here that is mechanically disrupting the thrombus, and following that, there is a catheter that is left in place for infusion. The girl had a cardiac arrest on table and required rapid pacing. She finally underwent thrombolysis and normalized her pulmonary arterial pressures, and she's doing well 5 years later. So acute pulmonary embolism is a varied presentation, and what we are interested today is in that which is massive pulmonary embolism that causes hemodynamic instability, which has a mortality of over 50%, and it is a very important leading cause of death, not just in maternal situations in the UK, but overall. So what is the role of interventional radiology in massive PE? Is there any evidence for anything that we do? First of all, massive PE is defined by various organizations like the ICOPER, MAPET, etc. But the overriding thing is that the patient is in cardiogenic shock or has a blood pressure of less than 100 millimeters of mercury. And why is that important? So when there is a huge amount of outflow obstruction to the right ventricle, what it then causes is decreased right ventricular contractility. The right ventricle starts bulging into the left ventricle, and then finally the blood pressure drops, leading on to cardiogenic shock and death. So the most important initial stratification, there are various classifications that go on to look at intermediate risk, high intermediate risk, and massive PE. But today's talk is going to be limited to massive PE. The question is there shock or hypotension, and is the patient at high risk? And if the patient is at high risk, then what are the options we have? Now, thrombolysis is a known option. It reduces death and recurrent PE, and this has been well shown by quite a few RCTs. But thrombolysis carries with it the major risk of bleeding. In about 1/3 of the patients with massive PE, thrombolysis is a contraindication because they've had recent surgery or for some other reason, as we shall see. So that brings us on to endovascular treatments. And patients with major thrombus load in the proximal pulmonary arteries are those which lend themselves to endovascular treatment. Obviously, there's a failure of systemic thrombolysis, and the British Thoracic Society says after about 2 hours, if the patient is not improving, then you might want to consider endovascular treatment. And if there are, obviously, like I said, contraindications to systemic thrombolysis. There are various options available to the interventional radiologist for treatment. Thrombus fragmentation with pigtail or balloon catheter is one such option, which is what I'm going to concentrate most on. It is a cheap option. It's been ongoing for many, many years, and it's well known across the world. There are newer options like suction thrombectomy and aspiration catheters like rheolytic thrombectomy, rotational thrombectomy that has come into the market. We will have a brief look at that. Now, when it comes to the usual technique of mechanical thrombectomy, we use an angled pigtail, you perform a maceration or disruption of the clot, and then you give intraclot TPA, and then you might want to leave a lysis catheter. How do we do that? So that is a typical picture of an angled pigtail that helps you to get from the right ventricle into the main pulmonary artery and into each branch of pulmonary artery as is shown. So if you look at this 43-year-old male patient, quite a significant amount of thrombus load, massive PE with low blood pressure, comes in, and what we've done is we've recorded the pulmonary artery blood pressure, which is a key indicator. So that is extremely high. You can see the thrombus load in there, and then we start thrombolysis. About 6 hours later, you still have thrombus within the pulmonary artery, but the PA pressures are falling, and that is an important indicator of success. Another patient, post-knee replacement, quite a significant amount of thrombus, 8 hours down the line after catheter thrombolysis, a good angiographic picture. What is the end point of intervention? Like other interventions, are we looking at trying to bring in a good angiographic effect, or are we looking to try and reduce pulmonary artery pressure? And if you go back to my slide on what is causing the problem, that is the right ventricular overload. So the important thing is judged by clinical improvement and reduction in PA pressure. Don't look for angiographic improvement. And usually TPA is continued up to 12 to 14 hours. What are the factors that potentially influence outcomes of these? It's the duration of the thrombus, whether they are amenable to lysing, thrombus load and location, of course, age and comorbid conditions have a thing on outcome of the patient, and clinical awareness at the point of clinical referral, because there are so many patients that are referred very late to us. When you go past mechanical disruption of thrombus, there is another way in which you can loosen up the thrombus as it may, and this is the ECOS technique. What it does is it tends to increase the space between the fibrin by using ultrasound waves, and thereby allows penetration of the thrombolytic agent and also allows for a faster lysis, if you may. Now, if you look at this particular patient, courtesy to my friend Narayan from Guy's and St. Thomas's, this is a young patient who came into ED with shortness of breath and had an arrest. So he underwent a CPR, so he had multiple fractured ribs and had a massive PE. So what was done was an ECOS catheter. I'm not sure whether you can see it very clearly. You can see on both sides of the lung, the ECOS catheter has been placed and thrombolysis given for 15 hours. And 2 days post CDT, you can see normalization of the right ventricle. The patient went back home after 6 days in hospital. Now, that brings us to the final component of it, which is becoming more common now. There are various devices that have been brought into the market which do not rely on thrombolysis for long duration, but actually sucking and extracting the thrombus. Now, there are various catheters like the Arai system. There are catheters like the Penumbra catheter or the Rotarex, Aspirex, which have come into the market for mechanical thrombectomy without the use of thrombolytics. It's early days. They offer an advantage of rapid dispersal and removal of thrombus, but it's largely been designed for use in peripheral vessels. One has to be careful because there are a higher risk of complications, especially pericardial tamponade. Some of them can cause severe hemolysis. They should be limited to the proximal vessels and not extended into the distal vessels. Now, if you look at the devices, either the devices like the AngioVac or the Inari are large bore devices, 22 to 24 French, or we have the small bore devices like the Penumbra CAT system, but if you probably think about it, there is some device that is somewhere in between this, which is yet to be discovered, which probably will find an answer to this solution. Now, what about management guidelines? The British Society is very clear. Thrombolysis is the first line of treatment, and invasive approaches should be considered when there are facilities and when there is a failure or inability to do thrombolysis. And that is kind of echoed by most committees. And now, with respect to the actual evidence and publication, we only have a class 2A evidence level C for thrombolysis, which is either catheter embolectomy or fragmentation. We are still gathering evidence with respect to the aspiration techniques, and we are now seeing a few trials that are coming through, like the FlowTriever trial and the Extract PE trial. In our own experience, we've treated about 42 patients in over 6 years, 17 patients coming in from the community, a large age range. 6 of them were undergoing CPR at that time. We have a high mortality rate. These are patients that are extremely sick, so 40% mortality rate, and most of those people who don't seem to make it are the more elderly cohort of patients. So in conclusion, ladies and gentlemen, endovascular management of acute pulmonary embolism remains controversial. There are no RCTs. All we have is good cohort studies. We need more robust registries or RCTs in order to establish that these techniques are ideal, and it should always be done in a combination of a PERT team, which includes a huge number of specialties working together to take care of these patients. Thank you for your attention.
Thank you, Dr. Lakshmi Yaran. We're going to go right to the next case. It's funny that I was taking a PERT call right in the middle of this, but we're right up with Professor Tang, and we'll have discussion at the end. Alex.
Thank you. My topic today is central giant HCC when surgery is a menace. These are my disclosure. A central HCC is defined as a tumor adjacent to the portal hypothesis, of which is less than 1 cm from major vascular structure. It usually locates in cornea segment 1, 4, 5, 8, or at the junction with a IVC. The essential selection criteria in surgery for HCCs are childhood class A cirrhosis, minimal portal hypertension of which platelets of more than 1,000, or hepatic venous pressure gradients of less than 10 millimeter mercury. The tumor size is not relevant to resectability. Circumference single tumors are better resectable comparing with a diffuse disease. Segmental localization amenable to resection is essential, either anatomical or non-anatomical. Adequate future liver remnant is also important. Microscopic vascular invasion is a strong risk factor for recurrent, and hence it should be taken with great precaution. The surgeons are very good in terms of surgical plane definition, its anatomical location, size, number, portal vein status, and future liver random. On the other hand, quite a fair number of them have lacking angiographic understanding of the arterial supply. This is a self-referred case of which is a 54-year-old male with hepatitis B cirrhosis by LOVA HCC CPS A6 ECOX 0 stage BCLC-B4. He was incidentally found to have raised alpha-fetoprotein of 1658 in September 2018. He was from Far East of Malaysia, and there were no MDT team in the institution concerned. The primary physician was a surgeon, and immediately he was taken to the theater with attempted liver resection, failed. Open liver biopsy was done and confirmed a moderately differentiated HCC, and it measured 15 by 13 by 9 cm. He was put on lenvatinib 10 mg daily by the liver surgeon without counter consultation with oncologist or a hepatologist. Progression of disease was noted, and by the time he came to see me, his liver his alpha-fetoprotein has gone up to 5,768. His liver function is slightly impaired. A CPS of A6, however, ECOG scales or still PS0. This was a CT scan in October 2018. By the time he saw me in December, the tumor has progressed remarkably, invading almost the entire right lobe, segment 4, as well as multiple lesions in left lobe. The IVC, hepatic veins, and portal veins are also quite badly encased. And by Kudos modified Moloney subclassification using Kinky criteria, he fell into the category B3. And in this category, it is a poor responder to CTase or DAPTase. Hence, HIC and sorafenib or tyrosine inhibitors are the option of choice. It was treated with HIC with concurrent TKI consumption. On the 10th December 2018, the hepatic CT arteriogram shows a huge diffuse hypervascular mass with minute supply from the central hepatic branches as well as peripheral territory. And the venous phase shows marked U-defined margin, which is an extremely poor prognostic factor. And this was a hepatic angiogram and right inferior phrenic arteriogram, which shows faint amorphous staining. We target to embolize the upper half of the tumor, and HIC with 50% dipyrodoxal mixtures sandwiches cisplatin was carried out. 50% of the tumor on the superior part was embolized or HIC using the regime. No gel form injection was administered. And this was the on table CT scan when it comes for second cycle of HIC a month down the line. It showed the upper half of the tumor was densely stained with dipyro and avascular. The lower half remains hypervascular as it was originally. And again, this time we target the lower half using HIC, same regime, and we add on tandem 100 micron. He continued to take his lenvatinib. Liver function was preserved. And MRI with Primovis after 2 cycles of treatment showed that marked partial resolution with moderate residual disease in the inferior third. It was again treated with another 2 cycles of HIC using the pyridoxorubicin and cisplatin with continuous lenvatinib consumption. On the 3rd and 4th cycle, embotract guidance using CT angio technique was carried out, targeting the relevant arterial supply, and that will offer a more selective and precise targeting. This was the 3rd HIC on 11 February 2019, which showed dense staining of the tumor after the injection. And this was an MRI after 4th cycle HIC, which showed the tumor is essentially avascular with a tiny residual rim in the inferior margin. And in view of the residual tumor, which is minimum, and the difficulty in getting access to the essential blood supply, we decided to offer the patient SBRT. And his alpha-fetoprotein has dropped from 6,524 on the initial HIC to 61.5 after 4 months. He showed excellent partial response. However, on the follow-up in April, his liver function showed a rapid rise in the liver enzyme and deterioration of serum albumin, and this was essentially a flare of hepatitis. The plan for SBRT was hence withheld pending the progress of liver function. He was sent home, and the appointment for follow-up after 1 month was scheduled. However, 2 weeks later, we received a call from a relative that he went back to see the liver surgeon who had promised him a total resection with minimal risk and complication. And it was an easy task as per the relative description. He was brought to the theater and attempted resection was done. After 8 hours of attempt, he died on the table, secondary to massive bleed. And this was very sad and appalling that a unilateral decision by the surgeon who was totally no clue on the stage of disease and the complexity of the angiographic changes. We were very distraught by the bad clinical outcome and the unreasonable liver surgery. Essentially, if you follow this paper, he fell into the group of resection because he's at intermediate stage B and good clinical grade, and being Child-Peel's A performance score of 0 is considered resection. However, while the surgeons are very good with surgical plane definition, he has forgotten about the angiographic supply to the tumor. And with a lack of angiographic understanding of this tumor, he has resulted in the mortality of the patient on table. And ignorance is a menace to peace in the social ethic. In the hospital, ignorance is a menace to safety. And greed is a disaster for the surgeon. Thank you for your attention.
Alex, that is crazy, and what a horrible ending that one could attribute almost entirely to surgical ego. We'll come back to it at the very end, but it's exciting to hear Dr. Para. Let's start this case straight from Toronto.
Good morning. My name is Dimitri Para. I am a pediatric interventional radiologist at the Hospital for Sick Children in Toronto, Canada. Thank you for inviting me to this session. I will present a case of an acute iatrogenic bad caries syndrome during hepatic vein dilatation. I don't have any financial disclosures. This was a 4-year-old boy who presented at 15 months of age with abdominal distension and palpable abdominal mass. The ultrasound that we can see here and the CT showed a large liver tumor compatible with an hepatoblastoma associated with free fluid and vascular invasion. At this point, it was considered non-resectable, therefore a port was placed and chemotherapy was started. This CT shows decrease of the tumor after a few cycles of chemotherapy. There was still some clot in the IVC. At this stage, the tumor was considered resectable and a right extended hepatectomy was performed. A right surgical venous conduct was performed, as you can see in the sagittal CT, and we can also see in this picture the single hepatic vein joining the surgical area. Unfortunately, a couple of months after the surgery, there was thrombosis. As we can see in this CT, there was signs of hepatic venous obstruction with enlargement of the liver and free fluid. A venogram from a femoral approach showed the known area of thrombosis associated with collateral venous flow. An attempt to recanalize the thrombosed area was unsuccessful. We then directed our attention to the hepatic vein, and the hepatic venogram showed stenosis at the area of the anastomosis that was treated with conventional angioplasty. There was recurrence of the symptoms, so conventional angioplasty was performed Q8 to 12 weeks. Unfortunately, there was recurrence of symptoms, and as you can see in this venogram and an ultrasound, the stenosis was recurring. We can see that it's very close to the right atrium. A stent at that point was not considered, as this child was still potentially a candidate for transplant. Unfortunately, the disease progressed and the child required a right pneumonectomy due to metastatic disease. He was also started in experimental chemotherapy. We offered the parents the use of paclitaxel-coated balloons, and with that, we were able to increase the space between dilatations to 17 to 22 weeks. The event happened when the child was coming for a routine hepatic vein dilatation, and at that point also it was requested to remove the port. He was asymptomatic. The week before had influenza. He was on warfarin, was switched to enoxaparin a few days prior to the procedure. This was the visit number 23 and the dilatation number 11. It was week 31 since the last dilatation. Access was obtained to the right internal jugular vein, and a guide wire was left in place to maintain access. The port was removed. A 9 French vascular sheet was placed. At the initial insertion of the wire, as you can see, the tip tended to go to the area of the anastomosis and was left there during the port removal. The single hepatic vein was catheterized, and this is the initial injection that shows a significant stenosis of the anastomosis. And in this figure, a few seconds after the injection, we can see very poor clearance of the contrast from the hepatic vein. As soon as this initial injection was done, the patient experienced sudden tachycardia from 120, reached 160 BPM. There was a drop of the blood pressure reaching 70/30 millimeters of mercury. The anesthesiologist told me, "Did something went wrong? Could you please stop what you're doing? The patient is unstable. We cannot continue." At that point, I removed the catheter from the hepatic vein to favor flow. An ultrasound showed early signs of thrombosis and very poor flow in the hepatic vein. A heparin bolus was given. The anesthesiologist gave phenylephrine and epinephrine boluses with partial response of blood pressure. Unfortunately, the tachycardia kept going up, reaching 190 BPM. At that point, we questioned ourselves and said, is there any chance of a PE? So we did a pulmonary angiogram through the sheet, and as you can see in the figure, there were no signs of pulmonary embolism. We placed a temporary CBL, we obtained arterial and good venous access, and we called the PICU team, thrombosis, and oncology. The situation got worse and worse. IV boluses of normal saline were given, albumin was given, the pH dropped from 7.2 to 7.1, the lactate went up, sodium bicarbonate was given, PICU started an epinephrine infusion. After 1.5 hours attempting resuscitation, the patient was in shock and the prognosis was deteriorating. The staff surgeon arrived, and in his clinical examination, he noted a significant enlargement of the liver. The ultrasound showed that there was new free fluid in the pelvis and there was progression of the hepatic vein thrombosis. A multidisciplinary discussion concluded that we had an acute hepatic vein obstruction resulting in a decreased preload, which explained the shock. We agreed that the only option was to try to unblock the vein. We performed an emergency angioplasty with a 6 millimeter balloon, and as you can see in this figure, there was a very, very good response, even though there was some residual clot, but the flow in the hepatic vein improved immediately. As soon as the dilatation was completed, there was an increase in blood pressure, and there was a slow decrease of the heart rate. The thrombosis team started an heparin infusion. The patient was transferred intubated to PICU and was stable overnight. The ultrasound the following day showed good flow in the hepatic vein and some residual clot that fortunately resolved in the next few weeks. In the area of the port removal, there was a significant hematoma secondary to the aggressive anticoagulation that resolved with conservative management. In conclusion, this was an acute iatrogenic Budd-Chiari syndrome secondary to a catheterization of a single hepatic vein that resulted in thrombosis. Etiology could be related to trauma during the catheterization. There might be a component of venous spasm. We know that this was a progressive stenosis, and I don't know if there was any potential role of the respiratory infection. We know that Budd-Chiari syndrome is a disease complex that results from obstruction of the hepatic venous flow, and if we don't treat it, can have catastrophic consequences. There are multiple etiologies, including post-surgical or abnormalities with coagulation, and the management relates to the etiologies and frequent in children, and probably the most common cause that we see of hepatic vein obstruction is post-transplant. In terms of iatrogenic Budd-Chiari syndrome, there are sporadic reports in the literature and are related to different surgeries as liver transplantation or hepatectomy. In this case report, acute iatrogenic Budd-Chiari syndrome is described as sudden life-threatening hemodynamic collapse and responsive to intravascular volume therapy and inotropic support, which is exactly what happened in this case. Learning points: consider the possibility of an acute Budd-Chiari syndrome when you're performing hepatic vein intervention, especially if you have a patient with hepatectomy and a single hepatic vein. The clinical presentation is a sudden life-threatening hemodynamic collapse and responsive to intravascular volume therapy and inotropic support. An interdisciplinary approach, communication, and collaboration is crucial for the success. And do not forget that this is a traumatic clinical event, therefore it's important to do team debriefing and emotional support. My main take-home message is that in this case, there was a rapid response to the correction of the hepatic venous outflow obstruction. Therefore, if I would have done something different, would be to do that emergency angioplasty early in the management. Thank you for your attention.
Thank you, Dr. Para. Heroic stuff. And now we're going to quickly move ahead and go to Kiang Hong Tae in Singapore, talking to us about aortic arch mycotic aneurysms. And we'll have some time for discussion at the end. Let's roll.
Good morning, everyone. First of all, I would like to thank the organizing committee for their kind invitation to participate in this session. I'll be presenting on a complication case. It's endovascular repair of a mycotic aortic arch aneurysm that has gone badly wrong. The patient is a 56-year-old man with a mycotic aneurysm of the aortic arch. He also has the following comorbidities. This is the CT angiogram, which shows the mycotic aneurysm, and the defect seems to be near the left subclavian artery. Coronal projection, again very near the origin of the left subclavian artery. This is the VRT recon. So this is a zone 2 aneurysm, and for open repair, you would involve a aortic arch replacement, or hybrid repair would involve TIVA with debranching to the arch vessels and bringing the stent graft to zone 1 or even zone 0. However, our cardiothoracic surgeons are not keen for the above due to the high surgical risks due to his comorbidities. And the calcified aorta also make cross-clamping during surgery difficult. So at that time, there were 2 case reports on treatment of arch pseudoaneurysm using the septal occluder device. So this is one such report of a defect in the ascending aorta treated with the occluder with good result. This is a second report. It looks pretty much like our case, successfully treated with ESD occluder combined with a chimney stent. So we are inspired by these cases, and because the surgeons were not keen for open repair, we thought we would try using a occluder plus a plugging of the left subclavian artery, and if this fails, we will proceed to a TIVA with a left common carotid chimney in order to bring the stent graft to zone 1. So these are the pertinent measurements, and these were the devices we selected. So we had hoped to perform this as an elective procedure after a full course of antibiotics IV, or at least the blood culture was negative before proceeding with the stent graft. However, the patient developed massive hemoptysis on the weekend, and the procedure had to be performed as an emergency case. Because he was unstable, we did not repeat the CTA. So this was the intraprocedural angiogram showing the mycotic aneurysm. Can't really see where the defect is coming from, but it was fairly easy to cannulate through the defect. So this is the stent in the common carotid artery as a precaution, just in case the occluder occludes the left common carotid artery. So the calcified aorta was quite a useful landmark to help us deploy the occluder accurately. Before the release of the occluder, the angiogram showed actually still massive leak across the defect. We decided to release the occluder to proceed with the stent graft. So this is the angio after the release of the occluder, again showing the aneurysm still being opacified. So this is another projection showing the leak. So to prepare for the TIVA and chimney, we have to puncture the left common carotid artery. This is the T-bar stent graft. This is the left chimney in the common carotid artery. Balloon molding, perhaps not a good idea in retrospect because of the friable tissue in that area. So to our disappointment, the leak persisted despite the TIVA. So we proceeded on to cannulate the subclavian artery to deploy the Ampluxer plug as planned. And the catheter actually went into the aneurysm quite easily. So this is the sheath for the Ampluxer, and again showed leak through quite a big defect over here. And as we were deploying the Ampluxer plug, we noticed that the AST occluder has shifted. And right in front of our eyes, the occluder flopped and dropped into the aneurysm sac. So this is the angio after deployment of the plug, still showing a leak. Tried to coil it some more, but the coil just floated away. So by now it's been several hours into the procedure and we decided that it's not working and decided to stop. The patient surprisingly got better and woke up and was extubated. And because he woke up, we repeated the CTA, which was performed on the 10th post-op day, which showed that the mycotic aneurysm was still opacified and in fact has its further increase in size. And this is likely due to a proximal type 1 endoleak. So this is the CT, this is the displaced coil and AST occluder. This is the Ampluxer in the left subclavian, which is occluding the subclavian artery well. The carotid chimney is patent, but there's not much seal zone here and the aneurysm is still opacified. Coronal projection showing the displaced occluder and the coil. Subclavian nicely plugged. Chimney is patent. So the plan was to do a carotid bypass, chimney the right innominate artery and extend the stent graft all the way into zone 0 ascending aorta. But during the surgery for the carotid bypass, quite a lot of pus was found in the previous left CCA puncture site, extending all the way into the mediastinum. So the surgeon decided that it's not a good idea to proceed and the procedure was abandoned. So the patient deteriorated over the next several days and eventually succumbed on the 24th post-op day. So the lessons learned from this case, probably we should have repeated the CTA and resized the aortic defect. Given that there were new symptoms, the aortic defect was probably widened, otherwise the AST occluder wouldn't have dropped off from the defect. Having said that, it's probably not a good idea in the first place to use this technique in an infected aneurysm, as the wall is quite friable. The outcome could have been quite different if we had gone straight with a right innominate chimney, carotid bypass, extending the aortic stent graft into the ascending aorta and plugging the left subclavian artery. Thank you for your attention.
Well, that was an extraordinary case, and we're treating a mycotic aneurysm in the face of the biggest flow in the body in an unstable situation. So I don't know how much you could have projected beforehand. Certainly heroic. We're going to move along to Dr. Goh, who is speaking to us from Australia. A complication taken to the heart. Roll tape.
Hello. I'd like to thank the organising committee of APSCVIR for their amazing organisation and for inviting me to be part of faculty and to present this very short case. This patient was a lady who was being treated for breast cancer. The nurses were saying that the port was not functioning, They couldn't access it properly. They couldn't flush. They couldn't aspirate. And they wanted the port to be removed. A chest x-ray was taken, and this is what it showed. So the port catheter had come apart or snapped at the junction with the port reservoir. The remaining port catheter had then embolized distally. It was now completely intravascular, lying in the central veins, the right atrium, and the right ventricle. Unluckily, or luckily, the patient was asymptomatic. This was somewhat surprising. Despite the patient being asymptomatic, it probably was not a good option to leave the catheter floating freely in the intravascular system. So what would you do next? Like I'm sure the rest of you would do, we performed an angiogram via a right jugular approach. This showed that the inferior catheter tip was wedged in the right ventricular apex, and the superior catheter tip was actually in the azygous vein, not in the SVC or right brachiocephalic vein. Thankfully, the patient was not suffering from any dysrhythmia. And furthermore, the rigidity of the catheter had stopped the catheter from embolizing to the pulmonary circulation. However, this meant that the end of the catheter was difficult to snare. Getting a snare around the inferior tip in the cardiac apex would be difficult. There's risk of dysrhythmia and damage to the tricuspid valve. Getting a snare around the superior tip in the azygous vein would also be quite challenging. What would you do? So a pigtail catheter was introduced via a common femoral vein access. The pigtail catheter was then wrapped around the catheter to present a free tip. Delicate traction was applied to pull the superior catheter tip from the azygous vein to the SVC. This then held the catheter in place for it to be snared. This presented tip was then able to be snared via the jugular approach. This was performed with a 3D end snare. The catheter was then carefully removed through the jugular sheath. The catheter was removed from the patient without complication. Hemostasis of the jugular venipuncture was achieved with digital pressure. The port reservoir was then removed and the port pocket was closed with dissolvable suture. So in conclusion, a detached port catheter is an uncommon complication. It carries the risk of perforation, thromboembolic sequelae, dysrhythmia, and distal pulmonary embolization. Foreign bodies in the vascular system can be removed with endovascular snares. And furthermore, a pigtail catheter can be used in conjunction with an endovascular snare in order to present the catheter tip to an endovascular snare for removal. Thank you for your kind attention.
Hello, my name is Jos van den Berg, and I will discuss the case of a complication during recanalization of iliac occlusion. We know that complications are many: perforation, distal embolization, and AV fistula, but there are many more, and I will show you another example. We're dealing with a 60-year-old patient. After CABG and harvesting of the great saphenous vein of the left leg, he developed an acute ischemia of the right lower leg. An CT scan showed a bilateral external iliac artery occlusion, as well as an occlusion of the right proximal SFA. These are the images from the CT scan. You can see that there is a small aneurysmal dilatation of the aorta, as well as a bilateral external iliac artery occlusion, and as mentioned, the occlusion of the right proximal SFA indicated with the red arrow. Please keep in mind these images very well, because we need to discuss the cause of the problem later. The patient was planned for an emergency procedure, giving the threat to the right leg. Case was performed by the vascular surgeon on call in a hybrid room. Recanalization was performed by him. Stenting was performed, and this is the control angiogram. And he was very happy with the result and thought did a good job. However, 2 days later, the patient's leg was not recuperating, and duplex examination showed persistence of a stenosis of the right SFA. Patient had continued ischemia of the right leg with developing compartment syndrome. So what to do now? We planned another procedure in the hybrid room. The plan was to perform a PTA and stenting of the SFA with a low SFA stick, and in the same session perform a fasciotomy. This is the low stick. You can see the fluoroscopy image on the left-hand side. The stenosis occlusion was confirmed, and you can see also that the distal outflow was good with 3 vessels run off. Stenting was performed of the proximal SFA, and you can see with a good result. However, there was suboptimal flow from proximal. You can see on the right-hand side the injection, the forced injection of contrast, not going up into the external iliac artery. Therefore, retrograde evaluation was deemed necessary, and retrograde recanalization of the external iliac artery was performed. And here you can see the fluoroscopic image of the wire passage that actually went outside of the stent, indicated with the white arrow. Then the wire was repositioned into the stent, and you can see that there was a loop formation proximal, but it was very difficult to advance any further. And this is the contrast injection into the stent, and you can see that there is no flow and stagnant contrast in the stent after a couple of seconds. At that point, a contralateral puncture was performed. Recanalization of the external iliac artery that was also occluded on the left-hand side was performed without any problem. Here you can see the angiogram, which actually corresponds to what we have seen on the CT angiography that was made prior to the first intervention. Still an occlusion also on the right-hand side, despite the presence of a stent. So there was a suspicion of an improper connection between the true lumen proximally and the true lumen distally. Here you can see the stent and the distal part of the common iliac artery on the right-hand side in more detail, and it's clear from this that there is a problem. Therefore, it was decided to perform an antegrade recanalization. You can see the use of a universal flush catheter, the wire on the right-hand side still in place retrogradely, and now it's possible to get into the space next to the stent, also from proximal, and then connection was made from distal, following the course that was initially made by the guide wire in the beginning of the procedure. Then it was not possible to advance the universal flush catheter any further. Here you can see the still images of these maneuvers, and here you can see the final position of the universal flush catheter and a multi-purpose catheter, both in the true lumen in the common iliac artery. Then this multi-purpose catheter was snared with an 018 guide wire, and because of the difficulty of advancing, a second guide wire was placed in a retrograde fashion, and here you can see the advancement of the multi-purpose catheter in crossover towards the distality, and then in the middle panel you can see cannulation of the introducer sheath coming from the SFA, and then connection was made. Here again, you can see the course of the multi-purpose catheter stent in place, an extra stent position of the passage, which is now a proper passage, and the snaring of the contralateral side. Pre-dilatation in a retrograde fashion was performed, and now we already have some flow antegrade when injecting from the left-hand side, and then a self-expandable stent was placed next to the already present stent, and here you can see the final angiographic outcome. So what happened actually? If you look at the CT angiogram, you can see a relatively narrow aortic lumen, which is not the entire aortic diameter because the thrombus. Looking back at the angiography performed during the first procedure, you can see that the appearance of the aorta is much wider. So here we are in the subintimal space. There's also no outflow, and actually this stump is exactly corresponding to the part that is missing here. Now looking at the angiography during the procedure, we now are sure that we are in the proper lumen, in the aorta, because the lumen is now more narrow. And you can see actually the same situation as before the initial procedure with the stent in a subintimal space without connection between the true lumen proximally and distally. So to conclude, always verify intraluminal position of your guide wire or catheter, especially when using glide wires or 018 guide wires that can really go with, inside the subintimal space without any resistance. And also make use of the pre-interventional imaging and make a kind of mental roadmap in order to avoid this kind of complications. Thank you very much.
Well, that was an extraordinarily amazing save. And now we're going to go from Switzerland a little further south to Italy to Dr. Ruffino.
Good morning, ladies and gentlemen. These are my disclosure. Endovascular therapy with implantation of covered stent has become a therapeutic option for treatment of arterial injuries with a minimal invasive and effective procedure that can be an alternative to surgery. They provide an immediate exclusion of the lesion with a redirection of flow through the vessel, minimizing the risk of distal embolization. They can be implanted only in presence of anatomic suitability, so we have a proximal lesion, an adequate proximal and distal neck, 5 to 10 millimeter length of artery before and after the lesion without arterial division, an adequate caliper, and vessel path allowing for safe catheter navigation. The data reported in literature about their employment in the treatment of arterial injuries are limited to small series or case report, while on the other side, we have on the market many different stent grafts that can be used with peripheral indication for the treatment of arterial emergency. Balloon expandable stent graft or self-expandable stent graft. Those devices are present in most of the department of endovascular department because they can be used also for elective procedure like revascularization of iliac artery, in case of self-expandable stent for using as a femoral popliteal bypass, or can be used also in particular for balloon expandable stent for a stent graft as a bridging stent for APSCVIR and chimneys. With this device, we can treat so many different arterial injuries. This is a case of an enteric iliac fistula that we treated with a balloon expandable peripheral stent graft 10 millimeter for 37 millimeter length with good result. And this procedure represents a bridge solution to the open surgery for this patient. In another case, in this case of a splenic pseudoaneurysm following pancreatic surgery, again, we use a peripheral stent, balloon expandable stent, even if outside their instruction for use for dealing with the lesion with good result after the deployment of the stent. Again, we have a superior mesenteric artery bleeding following pancreatic surgery. You can see this huge bleeding from from the superior mesenteric artery that we treated with a peripheral stent graft of 5 millimeter balloon expandable again. But there are cases, unfortunately, where the artery are small by their own nature, so just like in the case of this hepatic artery, where a peripheral stent graft could not be deployed because the smallest one is 5 millimeter, no matter who is if it's self-expandable, all balloon expandables, but what we needed was a smaller stent, and that's why we decided to implant a coronary stent graft. Also, in this case of a posterior tibial artery bleeding following trauma, we decided to use once again two coronary stent graft to exclude the lesion with complete restoring completely the vessel to the foot. In other cases, the vessels are big by nature, like in this case where we are dealing with a iliac artery, and we had an anastomotic pseudoaneurysm following renal explant, and the diameter of the artery was almost 16 millimeter proximally, and distally to the lesion 13 millimeters. So a conventional peripheral stent graft 10 millimeter, because available was not enough. So we decided to implant an aortic balloon expandable stent graft 2 actually, with complete recovery of the lesion and this control after the procedure, with complete exclusion of the pseudoaneurysm and direct flow distally. But also there are, again, vessels that they are bigger than what they are supposed to be. So this is a case of a perforation of a common trunk after angioplasty, coronary angioplasty through right radial access. The artery was almost 11 millimeters, so again, no peripheral stent available for that. And that's why, again, we use aortic balloon expandable stent graft with complete exclusion of the lesion. Our experience with a low-profile balloon expandable stent has been published recently, and where we have performed not only patient with peripheral stent graft inside instruction for use, but also outside the instruction for use. And we use also coronary and aortic stent to treat peripheral, visceral, and supraaortic lesion. And the result was good, with high patency rate during follow-up, also for the small diameters. My conclusion are that endovascular treatment with covered stent with preservation of distal flow is minimally invasive, safe, and effective in the management of arterial injuries and emergencies. The good trackability, the small profile of new available stent graft, their flexibility and conformability allow for the rapid treatment of lesion, even in case of tortuous anatomy. And in case of arterial injuries, we have to remember that the proper size of the stent graft is essential to achieve the technical and clinical success without complication or recurrences. Therefore, we need a wide range of stent graft. So dedicated peripheral stent graft might be not enough to deal with all the emergency, and off-level use of dedicated coronary and aortic stent graft in very selected patients might be considered. Thank you.
Thank you for that. That was great. A great review of the extraordinary diversity of visceral stent grafts and peripheral ones. Also some interesting data coming out about their lack of patency longer, even though they're acute safe. So a lot of good reading, but we're gonna pivot right now to Dr. Stibbs, who's talking to us from Lakeland, Florida. All yours, Pete.
Hi, I'm Pete Stibbs. I'm the Global Director of Clinical Service and Physician Education for Argonne Medical Devices, as well as a clinical principal partner at Lakeland Vascular Institute in Florida in the United States. And it's a pleasure to be able to present today venous reconstruction with post-chronic thrombosis and adjunct thrombectomy as a part of the Extreme IR and Complications section of the APSCVIR 2021 conference. First case study is 62-year-old female who presented to the vascular clinic with history of bilateral lower extremity edema, also abdominal superficial varicosities. The patient had clinical history of chronic DVT that was treated 10 years ago, and an IVC filter was placed but never removed. And then this was done at an outside hospital. And the patient came in with lower extremity ulcerations, which was managed originally by wound care. When the patient was seen initially, the patient had a CEAP score of 6. With post-treatment, it was down to a 4, but we still had plenty of bilateral lower extremity edema, which made us want to look and kind of evaluate for chronic thrombosis and conditions that may be causing venous stasis. So initial CT confirmation showed cable thrombosis, and you can kind of see here how the IVC is thrombosed off, and it was extending just above the IVC that was placed 10 years ago, as well as going all the way down into lower extremities with pretty profound collateral venous engorgement and collateralization. We talked to the patient, and based on the patient's prior history of having anticoagulation and still having it being unsuccessful, the patient requested percutaneous intervention. And in consideration of the patient's surgical comorbidities, trying to do this procedure as best as possible, percutaneous really was the best course of care for the patient. So the patient was brought in, placed on the table. Bilateral popliteal access was performed with the realization that both sides of the iliac and into the IVC confluence would have to be managed and cannulated to be able to reconstruct the IVC. And so basically utilizing a glide wire technique with a quick cross 135 centimeter catheter, both sides from the popliteal up were cannulated into the IVC. Also, right IJ access was obtained for control with the thought process, because there was thrombus that was invaginating above the IVC filter, we wanted to be able to go in and control that thrombus from above and be able to aspirate possibly and remove the IVC filter, which in this patient was the causative factor for thrombosis to begin with. But you'll notice in this image on the side of the page, you'll see that there was plenty of collateralization after we were able to negotiate and dissect up and get into the true lumen and kind of get our wires up in place. There was plenty of large engorged collateralization and vertebral vessels that were opacifying, showing exactly what we were dealing with. Once we were able to cannulate above and actually go from above from the jugular and get a good venogram, you can notice that there's a select IVC filter that was in place. It had been there for over 10 years, but there was a large bit of thrombus just above the IVC filter. And that's always an interesting question of how do you manage that. Some physicians will tell you, placement of an IVC filter above that thrombus and then mechanical maceration or some form of TPA lysing may be effective. I think either one probably is a good bet. In this specific case, it was a synergistic procedure because of the old and chronic thrombus. It was performed using both an angiovac, which was, by AngioDynamics, and the cleaner thrombectomy system from Argonne Medical. And what you can see here is that angiovac is just above that ball of thrombus in positioning just above the IVC filter. Now, the issue was when you're trying to aspirate and try to remove that large bit of thrombus, it definitely had multiple morphology. It was subacute and acute. So you were dealing with some really consolidated thrombus where the vacuum suction of the 22 French catheter alone was not being effective. We were moving a lot of thrombus around, a lot of blood around it, but not necessarily the thrombus. So going from below with a cleaner device and macerating from below made it much more effective and was able to break apart that thrombus, that kind of older, more consolidated thrombus, and allow it to be aspirated up into the angiovac. And after we were done with this procedure and did the initial thrombectomy, the filter was removed. And just kind of to talk about the two devices I mentioned, I believe that a lot of synergistic care can go into performing one of these complex venous reconstructions that may require more than just one standard device. The cleaner device specifically is a mechanical maceration device with a sinusoidal wire that spins at 4,000 RPMs. And it comes in a 65 and a 135 length. So it gives you enough distance to go from below to be able to go into the central venous system if necessary and perform thrombectomy. And like I said, it does spin at 4,000 RPMs. So it does a good job of macerating and morcellating the thrombus. Here's a quick video to kind of show how that works mechanically. What you can see here is you can kind of see this through a clear tube of how it's spinning. And that vortex effect, it spins at 4,000 RPMs. And so it recirculates the thrombus, breaking it down into really smaller and smaller particulate pieces. That allowed the next device, the angiovac, to be more effective. What you're seeing actually in the tubes below, you're seeing some of that fresh and some of that chronic thrombus that the cleaner device was allowed or was able to break up and mobilize, and the angiovac was able to suck out. Now, the angiovac, as I stated, it's a 22 French device. We placed it via cut down. But the advantage of having such a large suction aspiration system is that in large thrombus burdens, such as in cable thrombosis, that large catheter can help mobilize and pull out the thrombus and help clear out the IVC, restoring flow. So there's that kind of that advantage of using both a mechanical master device, which broke down the thrombus into small enough particulate, and that large angiovac system to allow those both to work more efficiently and in synergistic partnership, kind of break up that thrombus, and you can kind of see the different variable thrombus that was removed. Now, once that happens, you still have the issue of reconstructing the IVC. There's a lot of encasement of chronic thrombus that will not be able to be cleared with general thrombectomy alone. In this specific case, serial balloon dilation was performed from both iliacs up into the IVC to help kind of open, to compress that thrombus that was adhesing the cable wall together and kind of push it up to the side. And then reconstruction was performed, specifically using, in this case, Venovo venous stents from Bard Medical and Palmol stents up in the IVC portion to kind of restore flow. And here you can see we no longer see collateralization. We can see a full restoration of flow in the primary IVC and the reconstructed iliacs. So the question in doing any of these procedures is really, what is the long-term patency? And when you look at and we review the literature, it can be variable. We know venous patency, at least if we look at the initial IDE trials of the stents that are approved for here in the United States, where I'm at, whether it be, the Vici stent, the Venovo stent, other stents that are on the market, they basically, the Cook stent, they basically run with a patency rate at 1 year of anywhere from 84 to 88.3% based on those IDE trials. If we look at further clinical literature that is out a little bit farther, we had a great study that came out actually in 2020 that came from USC with Dr. Kuo and Dr. Dan Z, that basically looked at long-term patency of venous stents that were placed. It looked at over 1,094 stents. And even in that study, at 5 years out, you're still looking at fairly high patency rates, upwards to 80.9%, depending on how you look at it and what scale you're grading. So in the end, we do have variable data, but it does show promise in reconstruction of these vessels that historically, prior to these newer tools that have been out and about and available, we've kind of left alone. And these patients were suffering from chronic limb edema, chronic swelling, and certainly suffering from post-thrombotic syndrome and severe post-thrombotic syndrome when you're dealing with bleeding venous ulcers. I think in the end, when we look at this type of extreme reconstruction, you're really looking at the clinical outcome. You should be looking for wound healing as the primary driver when you do a reconstruction case like this, because it is very complex. It does take a lot of time, effort, and energy. I would say that you don't necessarily want to go in and treat all patients this way, but certainly when you're dealing with the symptomology of post-thrombotic syndrome, the symptomology that's being induced by total caval occlusion, these patients absolutely can have benefit with regards to long-term healing by being able to go in and restoring flow and reducing the pressure in the lower extremity, the venous space, and really tend to do well from that perspective of initial healing. Once again, I thank you for allowing me to spend time with you today. I hope you enjoy the rest of the conference, and thank you so much.
All right, and this is our last case, and then we'll have a little bit of time for discussion. I think we may be saving the best for last. Dr. Liang, bilioptosis after taste. I can't wait to see this. Let's see it.
Good morning. I am Dr. Liang from Kaohsiung Veteran General Hospital, Taiwan. My topic today is bilioptosis after taste for HCC treated with plaques and HAIC. This was a 51-year-old male patient transferred to our hospital for surgical resection of his liver mass. He was a hepatitis B carrier with liver function of child-poor classification A. CT images showed a 5.5 centimeter contrast enhanced mass with early washout in the right liver. His AFP level was 9.8. ICG test was 9.1%. He underwent intraoperative ultrasound with sole mass detected, and segment 7 and 8 segmentectomy was performed in July 2013. Pathological study confirmed the diagnosis of hepatocellular carcinoma, trabecular and acinar type, grade 2. His BCLC staging was stage B. Unfortunately, a small HCC recurred 4 months later and the RFA was performed. Local recurrence was noted 34 months after he received another RFA therapy. 1 year after, another 2.6 centimeter recurrent HCC with right intrahepatic duct invasion was noted. That test with DC bead was performed with cystic necrosis of the embolized tumor, but with progressive dilatation of the left intrahepatic duct on the follow-up CT images. In January 2018, a metastatic nodule in the right lung was noted, which resection was performed for this patient 2 months after liver tumor progressed with soft tissue lesion in the right hepatic duct. Also, large loculated biloma over right upper quadrant was found. It's seen that external drainage of the biloma and the oral target therapy was the last treatment for him. The response was fair with slow progress of the biliary lesion. This patient underwent another C-test in January 2019 and ultrasound and or CT-guided biloma drainage during that year. Unfortunately, massive bile was coughed up intermittently with a bronchobiliary fistula shown on the fistulogram. The fistula formation might be due to disease progress per se or transpulmonary drainage once. This symptom bothered him very much, and it lasted for 7 months. Finally, we were consulted for help. We performed a direct fine needle puncture of the peripheral bronchiole in the collapsed right lower lung in our Angel CT suite. After intrabronchial catheterization, we embolized the bronchus with plaque 4 and MPCA glue. The symptom of bile cough subsided afterward, but tumor progressed into the common duct noted. We performed PDPD for internal biliary drain and hepatic arterial infusion chemotherapy to treat HCC. The PDPD drainage catheter was removed before the second HAIC, which was around 4 weeks apart. After 6 courses of HAIC, there's no visible HCC or dilated biliary duct on the latest follow-up CT images. He is now in complete remission with symptom-free survival, even in the present time. A brief summary of this patient's clinical course as below. HCC was first diagnosed in July 2013. He underwent surgical resection. Between 2013 and 2018, he received radiofrequency ablation twice, DEP test and C test once for hepatic recurrence and wedge resection for lung metastasis. He started target therapy in 2018. Bronchobiliary fistula occurred in February 2019. The fistula was embolized in October. He received 6 courses of HAIC in the following 6 months with complete remission and symptom-free even in the present time. As to the hepatic arterial infusion chemotherapy, we modified the conventional regimen by adding 10 cc Lipiodin injection into the common hepatic artery after 5 days continuous chemo infusion with the hypothesis so that synergistic effect of chemo infusion and the embolization can be obtained. The therapeutic clinical outcome is quite promising for advanced HCC patient. This patient had a 10 centimeter HCC in the right lobe liver with the main portal vein invasion after 6 courses of our modified HAIC regimen treatment. Complete remission was achieved with disease-free survival for more than 14 years, even in the present time. This treatment is also effective for icteric HCC, as in this 81-year-old male patient, after placement of 2 bare metal stents for internal biliary drainage and 4 courses of our modified regimen HAIC, there's no residual viable tumor on the follow-up CT images. Unfortunately, this patient died of upper GI bleeding with disease-free survival of 17 months. From this case, we consider that angio CT suite is convenient and essential for several interventional procedures. Biolic or fistula can be sealed off by use of plug and or glue. Our modified HAIC may be effective for icteric HCC. Thanks for your attention.
Well, I am speechless. First, I can't believe that we got all of that done with all the tech stuff from all over the planet. So amazing and great recovery by the tech staff. Secondly, the diversity of the cases and things we saw is just mind-boggling. I don't even know where to start. And I certainly have never seen anybody cough up bile. I don't know if anyone else had. We have about 7 minutes for comments. So as the panelists are thinking what to say, I'll tell you one interesting thing, which is where did Extreme IR come from? And it came from a course in 2004 that I used to hold in the mountains, where we used to climb mountains and go rock climbing. And if you didn't make the trip up the mountain, you did not see the lecture, which was halfway up. So I think we have climbed some pretty big mountains here tonight with some amazing cases and also sharing some disasters. So some thoughts from you folks. I have one to throw out. That was a lot of dilations, and I know it's exotic to place it in the hepatic vein butt Chiari case, and really life-prolonging and life-saving, but any thought to placing a stent or even doing a TIPS in that infant, in that young baby?
You know, as I mentioned in the presentation, I think there were a couple of technical challenges. One was that the stenosis was very close to the right atrium, and we didn't want to compromise the possibility of a future liver transplant. That was the reason to explain so many dilatations. However, to tell you the full story, at the end, the child unfortunately recurred around the vein, so he ended up with a stent.
What a great follow-up. Other questions or other comments? Nice demonstration of how to pull something out of the abscous vein with a pigtail. Remember also the back of a bent wire inside of it, or a tip deflecting wire. Dr. Pua, when do you do a safari versus doing the venous dearterialization? Any quick tips for the audience on when you go one way or the other?
Well, I think that at least in our practice, almost all the patients that go through a DVA all have failed all kind of angioplasties. Now, when we switch to the IVUS, we really get lost quite often because as opposed to a like what you call safari access, where we put the venous wire up or venous balloon, you're really lost when you do the IVUS because you may go into peroneal vein or some other vein. So we are slightly switching back a bit more to the balloon puncture from the access from the vein. So that actually helps things a lot faster. That's why I feel, yeah.
Yeah, while we're at that, maybe I would like to ask Wei, what was the rationale to also reopen the anterior tibial artery in the case that you showed?
Oh, right. So that's a great question. I'm glad you asked the question, Prof, because I think that one of the main challenge with DVA is that we had done a couple, maybe a study over 20 cases. The technical success is very high. The problem is that clinical success is quite low actually, because we are doing them, I think, at the late stage. The problem is that the DVA takes about 8 weeks to really take effect. So in the meantime, the foot need to stay alive. And I think that we can open the arterial inflow to really tight the DVA maturation period of 8 weeks. I think that's the goal we're trying to achieve now. Yeah.
Right. But if you open the ATA, wouldn't you wait to see if the ATA itself is good enough?
Yeah, correct. So if you look at the history of the patient, you asked the question very well, Prof, really, because if you look at the history of the patient, he does have a lot of angioplasties done, and all of them, including opening ATA, all this did not help. See, so these are really end-stage cases. And I think more conceptually, we are trying to identify which are the patients that we should go to DVA earlier, despite having a good angioplasty, because some of them are set disease and stuff. But yeah, so this patient did have an ATA angioplasty, waited, didn't work, and that's the reason why we went on. As you could see, it was a rapid reocclusion itself. Yeah.
So I don't know if Dr. Yoon is on, pivoting to the hepatic artery, and whether your sounds. I've seen 3 of these cases, and we had one just a few weeks ago in a woman who it was discovered when she fell off her horse. And we did the same sort of thing, filled it out, and her transaminases, AST and LT went as high as 5,000. And every day we are debating, and we had put some stent grafts in, whether to go and reopen them that they occluded, or whether to just wait. And in another case, I had occluded it all, and these things had gone up to the sky, and finally they began to come down. But I'll tell you, I've never had such scary nights. I don't know if anyone else has seen that kind of acute reaction of near infarction and then get away with it.
We had a couple of cases, Ziv, where we've actually used stent grafts, across wire bands and VBXs. And we've kind of thought that it's all going to occlude. And much to our surprise, a year later, they still seem to remain patent. Of course, you need a bit of sealing zone right at the front end and the back end to do that, but really surprising. I don't know your idea of stent grafting hepatic artery aneurysms and they staying patent.
Well, I take your point, and we saw those great cases from Dr. Rufino of the emergency value and use. There also has been some interesting papers from Europe, some in JVR and CVIR, showing that while these have been acute saves, that a remarkable percentage of them have become asymptomatically occluded. Ours became occluded overnight. So still a challenging area. I had a question for Dr. Arai. Yep. When you decided that the stent that was your enemy suddenly became your friend in order to capture, what was your thought as to whether or not you could get the tube through the mesh of the stent? Had you already known that you would be able to stretch it, or were you trying to hold it and maybe come underneath the end?
Yes, that stent was the not razor cut, so-called I don't know. So it's not difficult, very easy to make the large hole. So it's possible to put the stent, put the tube through the stent wall. So, David, I have another question to others. It's okay?
Please.
Yes. So Alex and Professor Lin mentioned that showed a very good case response to the hepatic artery infusion treatment. So my question is, how to choose such a very good patient for the responding to the arterial infusion treatment, not the embolization?
Dr. Liang, do you want to answer first?
Yeah, if patients are not candidates for surgical resection, or we consider the response is maybe not good for conventional tests or depth tests, then we performed HAIC. And we call it as the HA19 for the poor patient. Yeah, the effect is quite similar to the HA19.
So I can understand that if there's a hepatic infusion is only the remaining the treatment, but sometimes it's very important how to find a chance to exchange to the treatment from embolization with others to the hepatic infusion. Alex, how do you think about that?
Well, essentially, those who come for HIC, most of them are also suitable for SIRT. Unfortunately, I think SIRT has a lot of kind of challenges, more toward the institutional availability. I can offer a service, but my counterpart has some challenges, so it becomes a challenge whenever we offer SIRT. So we switch more toward the HIC. But those HCC cases who come to me, I will put my transarterial internal embolization reductase as my priority, failing which those are not suitable, then we switch to HIC. And invariably, with the current technology, unless you combine it with some sort of systemic treatment like TKI or immunotherapy, it's not going to work well. So by doing HIC with 50% dipyral emulsion, together with lenvatinib or immunotherapy, we see very good result. And it has to be a staged exercise. I do not do hepatic arterial infusion through the port because the complication from the port is more than the just injection. So we just take the patient in, do the infusion, then remove the catheter, come back a month later to do the next session. We realized that actually the result is pretty good, and many cases we were able to turn them around. I think next session probably you have to organize one session just on this.
Thank you.
Can I ask a question? Sorry, a quick one.
Last question, we're wrapping up.
Oh, okay. Pardon my ignorance. So what is the difference between HAIC and TACE? From what I could see, it looks like it's TACE that you are doing rather than HAIC, right?
Well, in this situation, we mix 50% dipyral and chemo drug emulsion, which is 10 mils dipyral, 10 mils contrast with doxorubicin or epirubicin powder. So you just infuse it in. You don't embolize as dense as a TACE, and you do not embolize with gel form. So it's just an infusion. Technically, you may say the same, but the endpoint is a bit different in this situation. We do not emphasize in terms of this portal-vein obfuscation like myeloma grade 1, 2, that type of thing. So it's a bit different. I think Arai should be able to organize a better scientific teaching session for the AP level, I'm sure.
So I think we also want, as interventionalists, to remember that there have been some notable advances in systemic treatments like atezolizumab, bevacizumab, and it may be that your next pass is going to be that combined therapy, or that these types of masses and good liver function may see those as well. Amazing that you didn't have portal vein thrombus. I want to congratulate everybody on behalf of Dr. Arai and I and the organizers. You've put together some spectacular things, and I hope that this is a great beginning and a great turnout online as well. Congratulations, APSCVIR, for this opening session, and have a spectacular day. In the West we go to sleep, and the East, you guys begin. So yeah, we'll see you.
Thank you very much, all.
Thank you.
The Covera vascular covered stent is indicated for use in the treatment of stenoses at the venous anastomosis of EPTFE or other synthetic AV access grafts. The Covera vascular covered stent is made from self-expanding nitinol that is fully encapsulated between two layers of EPTFE, including the contoured covered stent ends. Each end of the covered stent has radio-opaque tantalum markers. The device is available in diameters of 6 to 10 millimeters and lengths of 30 to 100 millimeters. The inner lumen of the implant is carbon impregnated, which is designed to decrease platelet accumulation in the acute phase after implantation. The Covera implant comes in both a straight and flared configuration. The flared configuration promotes laminar flow and wall apposition in anatomies with a diameter increase at the outflow end. The Covera covered stent system is a triaxial over-the-wire delivery system. The catheter is comprised of a guide wire lumen, a delivery sheath, an extension catheter, and a stability sheath. The covered stent is constrained in the space between the guide wire lumen and the delivery sheath. Most covered stent sizes are compatible with an 8 French introducer sheath. The guide wire lumen originates proximally on the handle with a Luer hub and terminates at the catheter's atraumatic tip. The guide wire lumen is designed to accept a compatible 035 guide wire. A red safety lock on the handle is designed to prevent the operator from prematurely deploying the covered stent and must be switched to the unlock position when ready to deploy. The handle includes 2 deployment thumb wheels. Activating the large thumb wheel retracts the delivery sheath to deploy the covered stent slowly. The operator has the option to switch to the small thumb wheel and deliver the covered stent more quickly. Please consult the Covera vascular covered stent instructions for use. For complete product description, instructions for use, as well as all safety-related information, including warnings, precautions, and contraindications.
Selective internal radiation therapy, also known as SIRT or radioembolization, is performed using CERSphere's Y90 resin microspheres. CERT is a targeted treatment for inoperable liver tumors that delivers millions of radiation-emitting microspheres directly to liver tumors. The implantation of microspheres takes advantage of the fact that the normal liver parenchyma is primarily supplied by the portal vein, while the hepatic artery is the primary blood supply for liver tumors. By using this preferential blood supply, tumors can be selectively targeted and irradiated, leaving healthy tissue relatively unaffected. CERT is a minimally invasive therapy in which a transfemoral microcatheter is used to gain access to the hepatic artery supplying the liver. After mapping the hepatic arterial system and isolating the hepatic vasculature to prevent the deposition of microspheres in the gastrointestinal tract, the microcatheter is advanced into the position from which the microspheres will be delivered. The Y90 resin microspheres are administered through this catheter. Administration should be conducted in a slow and deliberate manner to reduce the likelihood of early stasis and retrograde blood flow. The CERT procedure delivers beta radiation directly to liver tumors using the tumor's arterial blood supply. The goal of the procedure is to allow the microspheres to directly target liver tumors via the hepatic artery, with enough focused radiation to kill tumor cells, while minimizing exposure to the remaining healthy liver tissue. The Y90 resin microspheres average 32 microns in diameter, which is small enough to flow through the hepatic arteries, but are too large to pass through the capillary bed within the tumor, where they become permanently implanted in the tumor. The resin microspheres contain the radioactive element yttrium-90, which delivers beta radiation over a relatively short distance, an average of 2.5 millimeters in human tissue. Yttrium-90 has a half-life of 64.1 hours. Therefore, 94% of the administered radiation dose is delivered in 11 days, with almost no activity remaining after a month. Understanding that beta radiation from Y90 resin microspheres only penetrates a mean of 2.5 millimeters in human tissue, it is necessary to deliver enough targeted microspheres in close proximity to each other to achieve the desired tumor kill effect. Two factors contribute to achieving this outcome. Number one, administering an appropriate volume of microspheres for a patient's specific liver tumor burden. And number two, enabling the microspheres to disseminate around the tumor surface to avoid potential radiation gaps where active malignant cells may otherwise continue to grow. CERSphere's Y90 resin microspheres were designed to take advantage of liver physiology and the hypervascularity of the tumor's surface to effectively kill liver tumors while sparing normal liver parenchyma. CERSpheres are designed to deliver their prescribed radiation activity over tens of millions of microspheres that purposely have a density similar to that of human blood. This allows the multitude of density-specific microspheres to remain suspended in the bloodstream long enough to be carried to the distal arterioles of the tumor's surface for broad coverage. Killing liver tumors is not just a function of total radiation activity delivered. It's also a function of radiation targeting and coverage. Clinical studies show that when used in combination with chemotherapy, CERSphere's Y90 resin microspheres can shrink patients' liver tumors more than chemotherapy alone, improve quality of life, and increase life expectancy. To properly evaluate the patient response from CERT, it's important to wait approximately 3 months to order and evaluate CT scans. This is because the normal tumor response from beta radiation is to subtly increase in size within the month or two following the procedure due to inflammation, and then decrease in size with the tumor necrosis that follows. In a small number of patients, treatment can enable sufficient shrinkage of the liver tumors to permit future surgical resection.
The Venovo venous stent system is specifically designed for the treatment of stenosis and occlusions in the iliac and femoral veins. The Venovo venous stent is a self-expanding nitinol stent that is available in 10 to 20 millimeters in diameter and 40 to 160 millimeters in length. Each stent end has 3 radiopaque tantalum markers and 3 nitinol markers. The ends of the stent are flared 3 millimeters to ensure adequate wall apposition. The Venovo venous stent is loaded on a triaxial over-the-wire delivery system. The catheter is comprised of a guide wire lumen, stent delivery sheath, and system stability sheath. The stent is constrained in the space between the guide wire lumen and the stent delivery sheath. The guide wire lumen originates proximally on the handle with a Luer hub and terminates distally at the catheter tip. The guide wire lumen is designed to accept a compatible 035 guide wire. The delivery system handle includes 2 deployment thumb wheels. The large thumb wheel slowly retracts the stent delivery sheath during stent deployment. The small thumb wheel retracts the delivery system sheath faster during stent deployment. The red safety lock slider on the handle prevents unintentional stent deployment. To learn more about the Venovo venous stent system, contact your local BARD representative. BARD, advancing lives and the delivery of health care.
SCADR drainage system has been strategically designed to help clinicians effectively meet their patients' drainage needs. Formulated to promote maximum drainage flow, the SCADR portfolio includes catheters for percutaneous drainage procedures, including abscess, nephrostomy, biliary, and centesis. Constructed with patient comfort in mind, SCADR catheters are both kink-resistant and easy to insert. The SCADR catheter portfolio is packed with key features that allow clinicians to achieve a high standard of care in a variety of patient types. First, the locking shoulder tip construction reduces the potential accordion effect during entry, while allowing for large skived drainage holes to promote maximum flow. In addition, each SCADR catheter is coated with the innovative slip coat hydrophilic coating, which when activated can ease insertion into the patient's body. Made from highly durable polyurethane, the catheter material provides kink resistance and is formulated for patient comfort. The The removable pigtail straightener is designed to straighten the pigtail shape and ease loading of the stiffening cannula and/or trocar to prepare the catheter prior to insertion. The Skater drainage catheters also include position markings that can be used to reference catheter migration post-placement. The clinician and patient benefits continue at the catheter hub. The hub is sized to match the catheter to provide a consistent catheter body-to-hub inner lumen size, thereby eliminating a bottleneck effect. Also, the locking system is designed for ease of use for the clinician to lock and unlock the pigtail, but is low profile with a snap-off tab for patient comfort. The Skater catheter placement procedure for abscess drainage is conducted under imaging via either the direct stick or over-the-wire method. Once the pocket of fluid has been targeted under imaging, local anesthesia is applied and a skin nick is created to insert the drainage catheter. The assembled catheter, cannula, trocar stylet is advanced into the body using ultrasound or other image guidance. After insertion, the trocar stylet is removed by releasing the choice lock from the cannula hub. Check that fluid is escaping or aspirate with the syringe to verify placement. After the catheter is positioned, the cannula is unlocked from the catheter hub. Holding the cannula stationary, the catheter is advanced further into the body to the desired location, ensuring that the pigtail is in the cavity. Then the cannula is fully removed. To lock the pigtail in its position, pull the locking tab gently to tighten the strings. While holding the strings taut, wind the string around the slot in the hub. Insert the clip onto the slot while holding the tab. Once secure, gently twist the snap-off tab and discard it. After making the skin nick, an introducer set is used to place a guide wire. The guide wire is placed through the access needle into the cavity and the access needle is removed. The tract is progressively dilated to 1 French size greater than the size of the catheter to ease introduction. Under imaging, the catheter and cannula are advanced over the guide wire into the body. Then the same previous placement steps will be followed. To assist in targeted catheter placement, the Skater portfolio offers a wide array of accessories, including introducer sets, introducer sheaths, needles, ISN, and blunt needle access. This system is complete with drainage bags for collecting fluid. Skater drainage system provides physicians with the ideal mix of product effectiveness and patient comfort.